Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And this week, as I am each and every month, I'm delighted to be joined by Dr. Craig Joseph. He is the Chief Medical Officer at Nordic Consulting Partners and a pediatrician. Craig, thanks for joining me for this month's episode.
Thank you for having me. Always a pleasure.
So we often start with COVID-19 because it's been a little bit like that elastic band that you keep snapping on your wrist. You can't help yourself. You snap and you keep thinking about it. It's been an odd month. We've started to see an increase in the vaccine rollout, but then this bizarre weather system took hold, and we saw this massive challenge across swathes of the United States, and we've seen a big decline. What have you seen, and what's going on in your area, and what do you think is going to be the impact?
Well, I think in the big picture, it's probably not going to be that significant of an impact. I'm hearing already that a lot of places in the country are already kind of ramping back up. They've always had, well, I shouldn't say always, for a while, we've had the ability to give a lot of vaccines. And the thing that has been holding us back has been the supply of vaccines. And so you're absolutely right. A significant chunk of the United States lost the ability to travel on roads or on airplanes. And so the vaccine couldn't get to where it needed to go. And so that's absolutely delayed. And it delayed areas, even California. San Diego was unable to, they had to cancel a bunch of their large vaccine clinics. But as I understand it, that ability to administer is still there. And now when a big bolus of vaccine comes in, they are able to kind of give it quickly, I think. And so I suspect that in a week or two, we'll be caught up and, be back where we wanted to be. So I think it was bad, and it was, some would say it could be predicted, but we shall overcome this.
So I think the interesting thing that I noted around this was that we've started to get ahead of the last mile. So I think not all states, but certainly some states had stood up a bunch of capability that would allow them to do mass vaccination. I know in my state, at least, I'm aware of 3 mass vaccination sites that are ready, but they were lacking supplies. And of course, the supplies tanked because there was no ability to get these vaccines distributed. So there was canceled appointments. That's going to have some cascade effect. I imagine that there's some second doses that were impacted, and they'll have to play a little bit of catch up. That will give us some data to look at in terms of the response for those individuals. But what I find interesting about this is that we've sort of flipped and gotten ahead from a distribution standpoint, and now we really have to ramp up the supply. Do you think we're going to be able to do that? Have we got the capacity to really get this? Because I was seeing, of the orders of 3 to 6 million a day necessary to start to bring any kind of normality in, the time frame of the year.
Well, as we're recording this, I'm hours ago starting to read about both Pfizer and Moderna saying that they're able to or expect to be able to significantly ramp up their production, that they've figured out, got some of the snafus out of the way, figured out what they needed to do with their factories, and that they are telling everyone publicly that they are going to be able to get the number of vaccines out in the U.S. at least, so that we can significantly put a dent in and start to make use of that last mile that you're talking about, which is with any type of distribution process, the most difficult, right? And if for those who aren't aware of what the last mile problem is, it's always been easy, relatively speaking, to get something from the factory to a supply center. It was just getting it to people's houses, to their apartments, to their places of work that was really quite difficult, because that was expensive and needed a lot of personal hand holding. And so now that we have that infrastructure in place, once the supply comes up, which apparently it's going to be soon, as in weeks from now, we should see significant ramp up. And the need is out there. The desire is out there. People are still very excited about the opportunity to be vaccinated. And so there's a big opportunity to really, change the direction.
And all good news. And, for a small subset of people, I forget what state, and maybe it was in multiple instances, there was some cases where some of the deep refrigeration units failed. So instead of wasting it, they went hard out and said, we're going to find. And I think that, the three places, one at least was incarceration, where they knew that they could find people. Great place to go, because there was lots of problems, continue to be. I think elder care, potentially healthcare facilities, I forget what they were, but they just literally went after it to make sure there was no waste. So some lucky folks, got vaccinated slightly earlier than they might have ordinarily. So there was some good news for some people and all of that. And I love the fact that they applied that. It's good to be lucky. I read about Rice University as well, right next to Texas Medical Center. Yeah, they just called for, they had a bunch and they were about to be destroyed. Just called for any college student who could walk over and get a vaccine. And so, much better to put it in someone's arm, even if they're not the highest risk, as opposed to throwing it away if that's what happens. Yeah, I find waste at this point is entirely unacceptable. There is no excuse for that. It needs to go. And of course, the other thing that is tied up in here, and it sounds like you feel that there is, I don't want to say, well, maybe there is less vaccine hesitancy from the population. There's still the desire to get vaccines exceeds the supply. So we've got a, demand currently. At some point that might change and we won't have vaccinated. I'm wondering where that eventually falls, and will it be high enough?
Well, that's the million or billion or actually $1 trillion question. Right now, you're absolutely right. There's a much higher number of people that want it than can get it. And what will happen? I would imagine it's going to be midsummer where we start to say, okay, we have now more than there are people who want to get it. And then what do we do? And how do we convince those folks to help, get us up to the level that we need so that we can, think about it, at least as much as we can, kind of getting this behind us and going on. I'm not sure everything in life will return back to normal, but I think a big chunk of everything in life could return back to normal, once we hit the numbers that we need to. And we don't really know what those numbers are. It's a moving target.
Right. I've seen a number of modeling tools that sort of take lots of things into account. And what was interesting, and it's almost counterintuitive when you first think about it, but of course it makes sense. If we pull off all of the restrictions and say, don't worry about masks, just, hang out and spread the disease, of course, that actually increases the total number of people infected, and that might get you to whatever herd immunity is for the population. Now, to be clear, not something I'm advocating, but hadn't even thought that the reduction in some of those controls was going to cause or could potentially get us to that level. So, there's so many factors, and obviously the folks that are creating these models are working hard, but I think for the most part, relatively good news, but, it's still going on for a lot longer than all of us would really care about. So word on travel. I mean, have you seen anything regarding travel? We've heard some closure or change in terms of the requirements. I think there was certainly some discussion internally to the US. Can you imagine this being required to test if you went from one state to another on an airplane?
I can imagine it. I can absolutely imagine it. and that's where you can actually enforce it. It would be relatively easy to do. I think it would decrease a lot of, certainly decrease travel. There would be people who wouldn't be willing to be tested and wouldn't want to know that they were positive. But actually at this point, I don't find anything unimaginable. Hopefully it won't come to that.
Challenge accepted. I'm going to keep on coming up.
That's fine. Dr. Nick, I think you should continue to push me, but so far, I can totally imagine it. I can imagine having the vaccine, having proof of vaccination as a requirement to go to the movies or to go to some movies, right? Hey, you want to go into this public place where we are relaxing pretty much all the safeguards? Maybe we'll have one theater or a part of the theater reserved for people who can show us that they've been vaccinated. And, there's certainly no requirement to go to the movie theater, and there's certainly no requirement to go to this side of the movie theater versus that side of the movie theater. But I think there will be people who are interested in that sort of that sort of consistency. Hey, I don't want to go to this place if I'm going to be exposed unnecessarily to people who have not been vaccinated.
What an interesting idea, folks. You heard it here first. Movie theaters with vaccinated sections.
I'm not, again,
I don't think that's as wild as it might sound.
I'm not saying, half of the movie theater. I'm saying if you think about a big movie theater with a bunch of, on the left you have 5 theaters, and on the right you have 5 theaters. Hey, we're going to put these 5 movie theaters over here, and you can only get into those if you've got proof of vaccination. And in fact, we might charge a little. I don't own a movie theater. Maybe I should look into that. Hey, maybe I'll charge an extra $2 to go into the more exclusive part of the theater, to go into the vaccine, the section where you have to prove that you've gotten vaccinated, because there might be fewer people who are willing to do that. And for a few extra bucks, I don't think I would mind that. If I once I get my vaccine, once it's my turn and I'm able to go get it, I think it would be. I think it's a reasonable statement. And so certainly if it works at a movie theater, it would certainly work at a plane. Or a train.
Yeah, I think it's going to work everywhere. And, I was reading just today that a number of the airlines are working together to find a standardized methodology. There's generally a view that it must be digital to preclude, some of the fraud that's gone on. We've seen multiple instances in different countries. I know in the Netherlands, in the UK, and some other countries where groups had been offering fake tests, negative tests to satisfy, which, is just frustrating. But, we've obviously got to take account of that. And they're trying to come up with a digital version of the yellow fever paper certificate that we're certainly familiar with. And I think we'll see something similar to that. But all going to happen over the course of time. For those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Craig Joseph. He is the Chief Medical Officer at Nordic Consulting Partners. And as we do each and every month, News You Can Use, our discussion on what went on in the past month, in this case, February. We were just talking about COVID-19, as we do most months, because it's really been a focus. But moving on to some other areas, I think you had mentioned the editorial that talked about technology that was maybe changing its perspective to something that's not quite the big ogre that the healthcare system continues to perceive technology to be. And I know you and I are slightly different, I think. Or at least I know I am. Maybe you're not different. You're just like everybody else. But
wait, I'm not even going to take that bait. There's no way I'm responding to that. Certainly I work in healthcare IT and have been told sometimes that the tools that I try to help implement and help doctors and nurses use are not always their favorite. And so I'm talking specifically about electronic health records and healthcare IT in general. Often has been accused of getting in between patients and their and their physicians and caregivers. And there's just been this editorial in the Journal of the American Medical Association was simply saying, hey, we have said these things, we have believed them, that technology really has been a hindrance in some aspect, but boy, oh boy, when there's a pandemic, it sure is helpful. And so kind of getting a different perspective without the ability to ramp up telehealth. Of course, people have been doing telehealth for the past couple of years, but at a very, very small scale. And to be able to ramp that up so that people could see their doctors or from their own homes, not for everything, but for a lot of things, really did, technology really did come and kind of save the day. So not always the ogre, I think.
Well, I know you certainly are in this camp, and I definitely have. I've always believed that technology is the great enabler. Now, it's not evenly distributed. It's not evenly accessed, and not everybody gets as much value from it. I think that's a failure in the technology more than anything else. But it's heartening to hear that at least there is some recognition. The other sort of data point I have to that is that if you ask 10 doctors that are using an electronic medical record, okay, we can take this away and put you back to paper notes, I'm pretty sure that 10 physicians are going to say, no, I'll keep this. Even though I don't like it a lot because there are some problems with it, I would still rather use this because the value exceeds some of the challenges and pain that I have to endure in the use of it. And I think we just have to fix that pain and agony and start to give something that works better for the individual.
Yeah, well, I could not agree more. And no one, you're 100% right. In that, 100% of physicians would say we will stick with technology and not ignore the electronic health record. It's kind of like, to me, going back to the days before Google. And almost anything I want to know right now, fact-wise, I just go to the search engine of choice, and I can find the answer to that question. So I still may not know how many angels can dance on the head of a pin, but if I want to know what the atomic number of strontium is, and by the way, I don't know what it is, but if I wanted to know what it was, I could find it very quickly. And if we were to stop using electronic health records, we would go back to those days where I need to know what happened, and I can't just find out.
So 38, just so that you know, it's.
And you didn't look that up, did you?
And the atomic mass is 87.62. It has 2, 8, 18, 8, and 2 electrons per shell. But I just know that off the top of my head.
Yeah. Well, you paid attention in chemistry, and I think you should be.
I loved chemistry.
Lauded for that.
I realized this when I was reading through my old school reports that my parents were kind enough to keep going back to when I was 8 years old, actually younger than 8. And it was very evident that I loved chemistry, albeit I was a little bit of a troublemaker. I had a tendency to double everything, which I do in the kitchen as well. It sort of carried through. But that wasn't a good strategy in the chemistry lab because it created an awful lot of challenges with some of the reactions. We had an evacuation courtesy of me one time. It was all to do with chlorine gas.
Well, what's a little chlorine gas among friends, really?
Well, yes. It was a big ventilation problem. Anyway, side note. So,
I hope the authorities are not listening to this. I'm not sure what the statute of limitations is.
I think the statute of limitations and countries comes into play here. So, but I was held responsible. But I take responsibility because it was definitely my doubling of the contents in that particular. But that was because I loved it so much. I wanted to see more of the reaction.
Who could question you, really? I'm sure. Once the cleanup and the fire department went away, everything was good.
Yeah, exactly. But I think you're right. I mean, it's interesting that you highlight that when you think back to days before Google. And, I do remember that as a search engine. And it replaced, I used to carry around, I think bookmarks and the collection of bookmarks that I copied in, files and HTML formats and all the rest of it, that was my Bible of access because I couldn't remember how to find it. Now I don't even care. I don't even know if I have any bookmarks, if I even care about them, because it's not relevant anymore. And I think, that's true with a lot of information. And I don't think we've quite gotten there with healthcare information. Do you think, as a physician, can you get to things just by using decent search at this point, or is it there's still more work to be done?
It's getting a lot better. So are you talking about specifically in the EHR? Yeah. There's in many of the major EHRs, there is a search box, and I think the functionality is getting better and better. So it's always, I think, easy to type in a word. So if you're interested in searching for high blood pressure, typing those words in and finding where in the chart that's mentioned. However, it's actually a little smarter now because, of course, if hypertension is mentioned, that's the same search. And so I need the system to be smart enough to find that. A lot of them are.
Are they?
Yeah, they are. Absolutely. And same with HTN is how we commonly abbreviate, or in the olden days, abbreviated hypertension. And so, finding those things is absolutely, for those common searches, is absolutely doable in a lot of the bigger ones. Yes. But interestingly, I find a lot of physicians don't think about it. Like if they want to know anything from the internet, they go to Google or wherever they want to go and just type it in, and they know a common misspelling or another way of saying it it's going to pop up because science. That's why. And they can do that in a lot of EHRs, but for some reason they don't think it's there. It doesn't work 100% of the time, but 90% is still pretty good.
Yeah.
So I think it's there.
And I think, that data normalization and the cross-referencing with terms that are used that you would want to find, I think is important. That's part of that sort of application of natural language processing, which was, very much the artificial intelligence, although it wasn't called that at the time, but that was very much the sort of purpose, although we don't even necessarily have to tag data as part of the process. It was codified to allow for that in the early days. Now there's less of a requirement to actually codify the data so that you can get to it, even if you don't know the right search term to find all of the hypertensions.
Yep. Yeah. Well, I think the technology is catching up, but I think if you ask most physicians, they will say it's not.
So that article in JAMA is points to one particular instance, but we've still got work to do, unfortunately. So the march continues to try and improve the user interface. Closing minute, any thoughts as to how we fix that problem? I mean, what one thing do you think you could change in the electronic medical record system that would really bring huge impact?
I'll tell you what I think it would be, and it would not be inside the electronic medical record. It would be outside. It would involve the people that use it. Allowing the concept of a care team, I think, would be the biggest benefit to the patient and to the physician. Allowing others who are not physicians to work at the top of their license and to do things that they have done for a century, at least decades, and can no longer often do. So back in the day, I had a medical assistant, and she did a lot of work. She would start notes. She would do rapid strep tests before I even walked in if the patient met certain criteria. And nowadays you see that very rarely because of our regulatory system and our legal system, and because most doctors now work for large corporations. So that's the thing that I would like to see the most. And the American Medical Association, believe it or not, has been working to try to make that happen, to remove unnecessary administrative burden. So I know your question was about technology, but boy, I think the technology would work much better if people would allow non-physicians to help to function in the world in a safe and effective way. Stop
asking physicians to enter data points that could be entered by others, and stuff.
Absolutely.
And I would say that my pitch would be for clinical architects that are clinicians that understand the workflow, understand the detail, that orchestrate. And I'm borrowing from a good friend of mine, Dirk Stanley. This is something that he talks about extensively we have architects involved in building buildings, but you still have a contractor who actually puts it all together. You've got the basic ideas. These individuals that sit in the middle that essentially translate and understand both ends of that spectrum, I think will bring maximum value to optimize the workflow. And, I'm with him on that. I think, an essential part of our future, but not enough of them around. So we need more of those folks. Anyway, as usual, we've run out of time, unfortunately. So it just remains for me to thank you, as usual, Craig, for joining me this week.
Again, always a pleasure. Thank you.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com, and tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.